Okay, so we are live on the YouTube.
Right.
Start the meeting now. Good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have very young Dr. Kalhan Ambardar. He is MDS and FCLPS, that is consultant maxillofacial surgeon from Vadodara. He did his MDS in oral and maxillofacial surgery from College of Dental Sciences, Devangiri at Karnataka, and he did his fellowship in cleft lip and cleft palate surgeries from BMJH, Bangalore. He also won an award called Dr. G.B. Sivamurthy Award for topping the MDS exams, and he has several other awards to his credit. He has to his credit national and international publications. He's guest speaker at several conferences, and currently is affiliated to KGP Children Hospitals for Smile Train project and other hospitals in Vadodara also. And he has a decade of experience with more than 500 surgeries. With this brief introduction, I invite Dr. Ambardar to talk about virtual surgical planning in maxillofacial surgery. So over to you, Dr. Ambardar.
Thank you so much, Dr. Satish. It's really an honor to be part of this prestigious club, the Saturday Club. It's my first time here. I had only heard about it, but thank you to you and Dr. Jagdish for giving me the opportunity to share space with in this esteemed panel. Um, so, my gratitude to everyone who is attending this as well. If you permit, sir, I'll share my screen and start
Please.
the.
Yes.
Okay. Sir, is the screen visible completely?
Yeah, very well visible.
Okay. So my topic, as Dr. Satish mentioned, is virtual surgical planning in maxillofacial surgery. And the introduction that he gave was very humbling, and again, I extend my gratitude to him. After finishing my fellowship, uh, it was the vision of Dr. Jagdish to have an oral and maxillofacial surgery department in KGP Children Hospital. And with that, I joined. The same year I finished my fellowship. And subsequently, in 2018, under the able guidance of Dr. Hiren Bhatt, who is the senior plastic surgeon in our hospital, I was able to join Smile Train, which is an institution that funds cleft lip and palate surgery. Many of you might be aware of it. And since then, with the guidance of the seniors, we have been able to culminate a comprehensive cleft center in Vadodara. That's one of our feats that we have achieved, which means that anything to do with clefts, right from birth counseling to nasoalveolar molding, right up till rhinoplasties, we are offering free treatments, and a complete comprehensive center has been created. Now, as a part of this cleft center, virtual surgical planning was recently added, which is what I will be speaking about in maxillofacial surgery. But a very brief introduction about what actually oral and maxillofacial surgery is. So no surgery can begin without paying homage to the great Shushruth, who was one of the pioneer surgeons of the world back in 1000 BC, and performing facial surgeries, rhinoplasties at that time, something that even today experienced surgeons find difficult to step into. But honestly, oral and maxillofacial surgery catapulted in the World War II times. That is when trench warfare started. The soldiers were exposed, only their heads were exposed, so they would get a lot of ballistic and gun injuries in the face. And there were on-site doctors, general surgeons. At that time, plastic surgery had not developed as a branch. So it was generally ENT surgeons that took over and specialized into oral and maxillofacial surgery. One of the greats were Sir Harold Gillis, if anybody has heard. And then today we have a time when this is the Chief Minister of Tripura. He is a maxillofacial surgeon, and on chair, as he holds office, he also sometimes performs surgeries occasionally. So we've come a long way. It's a perfect blend of understanding the principles of occlusion, dentition, the skeletal aspects of the head and neck, the facial drape that we can see, and which involves principles of facial plastic surgery and medicine. And it is not limited to just a core specialty by itself. It has sub-specialties now, namely trauma, TM joint disorders, cleft and craniofacial, orthognathic surgery, pathology, cancer, implant, and dentoalveolar. Now, one can super specialize into these sub areas. By the grace of God, the mentorship of Dr. Hiren Bhatt and the vision of Dr. Jagdish, we have been able to do almost every kind of subspecialty practice in Kashiben Children's Hospital, except in oral cancer, because that involves adults and it is generally performed in a cancer center. So today I will be talking about virtual surgical planning in a few of these subspecialties, because it's not possible to cover all of them in a single lecture. I will begin with orthognathic surgery. And orthognathic surgery is, some of you might be aware, this is Hugo Obvesegger, considered as the father of orthognathic surgery. Basically, in 1950s, he designed certain cuts in the upper and the lower jaw in such a way that we don't lose the osteotomized segment, but we can slide these segments ahead, forward, and rotate them up and down based on our needs. So such kind of cases where you can observe that there is a disharmony between the upper and the lower jaw. You see, in this case, I don't know if I have the pointer, but either the upper jaw is deficient or the lower jaw is excess or the mandible is short. Now, in such kind of cases, these orthognathic surgeries are performed. Traditionally, this is how a planning would be done of an orthognathic surgery. Okay. So we would take photographs of the patient, and we would take lateral cephalograms, and we would make something called as these casts on the articulars on the articulator. Now, this is a very laborious process. You'll have to pour these casts in plaster of Paris and arrange the occlusion, and then modify them and cut them. And this is how a prediction tracing would be done. I'm not going into details because we are going to jump to virtual surgical planning. So we would physically trace on these X-rays that you see, we would physically trace these drawings and then predict how much we are going to move the jaw forward or backward. And we would guide our surgery with the sprint like this. So it was a very laborious process. We still do it. Additional planning would be conducted. Now comes in the virtual surgical planning for orthognathic surgery and 3D printing, which is a new technology nowadays. So you see, what we do here is we take high resolution CT scans, calibrated 2-dimensional pictures, and the cast in STL format, which means that this is the CT scan, which we are all aware of, but we take high resolution 3D CT. And the cast that we saw that Paris, which replicates the dentition in a patient, is now virtually made through an intraoral scanner. That means we do not need to have a plaster pouring, etc. And we can, on computer, get a 3-dimensional image of the same thing that we had done earlier. So, and then we take 2-dimensional calibrated pictures. So you can see that these pictures have markings on the patient's points, which we will superimpose on the CT scan, which I'll just show. So if you can see this video. So what happens now with 3D virtual planning is that the patient's cephalogram and the patient's CT scan is now superimposed on the photograph, and we can actually see in real time how the jaws and the soft tissue drape is behaving together. Now, this, along with, you can see different colors of marked in the bone. These different colors are where we wish to place the cuts on in the surgery. So even that can be planned, and I'll show you how. The physical tracing that we used to do with the X-ray that I just showed is now done by a software. Now this software automatically tells us, you can see how it's, the green is where we want the jaw to come, and the gray is where the jaw is currently. So all this prediction can be done via this software, and we can place our cuts, we can visualize real-time effects on the condyles of the mandible, on other structures of the skull, and we can see that we can place cuts anywhere as we like. So these are the cuts. This is how we give cuts in a software. And you can see that the orange part, this is a BSSO cut, and I'm not going into details, but I'll show a surgical demonstration for the same. And after this, you can see, I'll show this video. This is how we can plan the surgery. We can actually move the jaws in real time and plan it and see where our jaws are going to come after the surgery. Are they coming in sync? Is there symmetry? Is the occlusion maintained? Are we not damaging any vital structure in the face? So all these can be seen in real time through virtual surgical planning of the patient. Another very important aspect here is that we can actually predict some soft tissue changes. You can see that when we want the jaw of this boy to come forward, when we place it forward, the soft tissue, the real change also comes forward. So we can actually show the patient, you can see there that the face is coming forward now as we want it to come. And we can actually guide the patient so as to what your face would look like, probably not 100% accurate, but probably post-surgery. And then we can fabricate the splints that we used to do with wax earlier, I had shown. And the same thing can be fabricated in acrylic, which means that the new position of the jaws where we want them to be, at that place, this yellow strip that you see here is the splint which will guide us in the surgery. I'll show it through a demonstration. And finally, we can also superimpose our results, or what we had planned versus what we achieved. So the white would show what we had planned and the yellow would be what we achieved. So in this case, a good superimposition. And you can also see where you went, where an error was made or where we went wrong, so on and so forth. So let's look at a few cases to understand this better. I'll show a simple case first. Here is a girl with upper face deficiency. You can see that her maxilla is retruded. It's behind the mandible, which is neither aesthetic nor functionally good. So we would want an advancement of the maxilla. So we have taken 2D calibrated photos, and instead of the traditional planning, we went ahead for virtual surgical planning. You can see that the CT scan shows the green part is the maxilla that will get forward. The purple part is the mandible that will go behind. And the yellow part is the mandible that we want to stay in this exact same position. And the prediction tracing is done. This is how it will be done in a software instead of in real time, how it's traditionally done. And we'll go ahead with surgery. Now, before surgery, the new position of the maxilla and mandible, as I had explained, will have this splint, which you can see in between the two jaws made. So this will be 3D printed in an acrylic material. And we'll go ahead with surgery. These are some of the images of the surgery I'll be showing. And this is the bilateral sagittal split osteotomy. This is how we split the mandible and free the anterior part freely floats. And this is the sectioning of the maxilla. And we down fracture this maxilla and we can move it in any direction we want. And now this is the splint that I was speaking about. This is the splint according to which we will guide the two jaws together because we want them in a specific position, and we will plate these jaws into their new position. And you can see a significant difference in the patient's profile. while she was retrognathic jaw, now she has a more harmonious face with good proportions. But unfortunately, this is not what we get regularly. We get more complex cases in our center because it's a cleft center. So we get cases like these in which primary surgeries have been done. So here is a case of bilateral cleft lip and palate operated case in which there is a retrognathic maxilla, and she has a prominent chin, and she also has a unaesthetic nose, which adds to the quantum of problems. Now, in this patient, this is how you can see that the upper jaw is behind and the lower jaw is in front, and the teeth are not meeting, as you can see. So chewing is another problem. So prediction tracing. Now, here is an important point. We do not abandon the traditional methods when a new technique comes. It is very important to go with what traditionally we had known, and then parallelly do the virtual surgical planning so that we have both outcomes, prediction of outcomes. So here is a splint created, but also the 3D planning is being done in the same manner. And CBCT, which is a new modality nowadays, also gives us exactly where the vessels are. You can see the descending palatine and the nasopalatine in this patient. And this is the splint that I was talking about, the acrylic splint, which will guide us in the surgery. I'll just show a quick video of the surgery. I'll not keep it for long, but this is how we raise flaps. I'll just forward this part. Yeah, this is how we raise flaps and we give cuts on the patient. This is how we section the maxilla into two. I'll just let this video be for a few minutes. This is just for orientation. And we section it from behind at the pterygomaxillary junction. And we have to completely dislodge the maxilla. So this is a graphical image, and I'll show the surgical image also now. Yeah. So the same thing in the patient, real time. We are sectioning the maxilla through the cuts that we have placed. And you can see the chisel going inside. Similarly, this is the pterygomaxillary junction, the pterygomaxillary disjunction on both sides that is being performed. And this is the septum being sectioned. So we are sectioning the maxilla in the, and yeah, that's we are trying to down fracture a little bit. So we are sectioning the maxilla. And now after this, we down fracture the maxilla. Now this is easier said than done. It takes a lot of effort, as you'll see how we down fracture this maxilla below. Yeah. Yeah. You can see that the maxilla is completely down fractured. And after down fracturing, we need to mobilize the maxilla. I'll skip this part a little bit because it's long, and I'll show you how we have mobilized. Yeah. So we need to see how we mobilize the maxilla. Yeah. This is the reflection of the nasal layer. Yeah. So this is detaching the maxilla from behind the musculature and the soft tissues. This sort of completely disjuncts it, and it needs to be freely floating. Yeah. Now this is how it should be freely floating. And you'll see that, yeah, that's how the maxilla is freely floating in the patient's mouth. Now we can position it at any point we want. In this case, we want to place it 8 millimeters in front. And for this, how do we know 8 millimeters have crossed? Because we have the splint. Now that splint is given to us. Earlier, it was given to us by traditional methods, but now we have 3D printing that gives us. So this is the splint. This is how we'll place it. It guides us. And that's what we will do in the patient. And we'll plate it. So this is how, yeah, you can see the splint in between, if you can observe, between the two jaws. This is the 3D printed splint. And now we know that we have put the maxilla in the right position. It was behind and now it's in the right position. and then we plate it. So you can see the difference in this patient post-surgery, how her profile has improved significantly because her maxilla is quite behind. Now it's harmonious. Of course, she needs a rhinoplasty, which is planned for as a different procedure and is a matter of different discussion. Similar cases can be performed through anterior maxillary distraction, in which we section, when we don't have adequate teeth or adequate dentition, we section the maxilla in between rather than the entire maxilla. This is something that we have, we do commonly now at our facility. So we place this distractor. This is a distractor that basically, if anybody is aware of Ilizarov's principles of distraction, who he had done distraction osteogenesis in the thigh, the femur, to lengthen the height of the patients. So we use the same principle, and this is a distractor that sort of advances this maxilla front slowly and gradually after a latency period of 1 week, and we place the cuts in this fashion. This is how the cuts are placed. Anterior maxilla only. I'll just show you. This is one of our patients, and you can see that we have cut the anterior section of the maxilla entirely, and it's mobile. It's not as mobile as the last case because here it is attached to the hyrax, which is the distractor, intraoral distractor. But this shows that it is completely mobile, and on the other side as well, you can see how the maxilla is entirely moving. And this is how we will open the distractor. This is just to check. You can see the two sections are moving apart. And this is to check whether it's opening or not. So that's what we do. And after 7 to 10 days of latency, we start distracting 2 turns per day. And we get an effective advancement of 10 to 12 millimeters. So you can see our results again, that the patient's profile completely changes after such kind of cases. And this is the amount of distraction that we can get, almost more than 12 to 15 millimeters. And some of our cases, I'll just run through these. Big profile differences in these patients. You can see significant aesthetic changes. Facial asymmetry, very complicated cases, but here also sometimes there is agenesis of the temporomandibular joint itself, the condyles. So in such cases, we will do a virtual surgical planning and we'll add a joint. So this is temporomandibular joint replacement. So a prosthesis like that, like we have in the knee joint replacement, similar prosthesis is planned, as you can see. This kind of a prosthesis is a joint is created. It's a stock prosthesis. And this entire thing is created virtually. And it can be designed virtually, custom made according to the patient. And then we can print it. The joint can also be printed. As you can see, this is how it's attached, the joint, and a surgery can be made. So the entire surgery, whatever processes are there, become more controlled and our outcomes become more targeted. So this is how the superimposition can be done. And you can see a significant difference here itself, that the patient is now having a new joint. This is where he started from, and this is where he has a new joint now, and asymmetry has been corrected. A similar idea in malignancies can be performed, which means that I'll just share a case and we'll understand. A case of osteosarcoma of the mandible in which hemimandibulectomy was performed. The entire mandible was removed, and we need something to be placed in that region when the mandible is, half of the mandible is out. What do we reconstruct it with? The go-to osteomyocutaneous flap is the free fibula flap. We take a section of the fibula and we place it. Now, earlier, this would be done in a traditional manner. We would just measure the distance on table and cut that section of the fibula and place it, but not anymore. We can visualize the defect. We can cut the defect of the mandible by the guide, which you can see in the pink structure there. And even on the leg, we can design the exact shape and size of the fibula based on guides of the virtual surgical planning. You can see we can print these guides. What we see on the computer, we can print it in a 3D printer and take the fibula cut the fibula as per our needs and bend it and attach it, you can see how it's being done. And we can take the stereolithographic model of the mandible, which you can see here, and actually adapt these plates so that we save a lot of time in the OT and we get a near perfect result in reconstruction. Exactly how we had planned in the computer is what we can replicate on table. Similarly, dental rehabilitation, patient with a extremely mutilated dentition, all terminal teeth, no chances saving. And if you look at the orthopentomogram, the patient has barely any bone left in upper and lower jaws. So how do we rehabilitate her dentition and occlusion? Well, again, we can plan up to the millimeter of wherever there is some amount of bone. A customized implant prosthesis can be planned, and we can place these implants in the patient's jaw. Even if there is minimal bone, we can place it via a guide in the perfect position, and we can give a prosthesis. We can give the entirely, an entirely new dentition. This is a 62-year-old female patient who was about to lose all her teeth, but is now rehabilitated. So these are things that can be performed. This is a glimpse of virtual surgical planning in maxillofacial surgery. And to sum up, virtual surgical planning is not absolute, but a more controlled method to plan, execute, and evaluate outcomes. It should be remembered. Principles of surgery are the robust foundation on which technology progresses in our fields, ultimately leading to better patient care and outcomes. I again thank each and everyone for this patient hearing and this wonderful opportunity that has been bestowed to me, extended to me. Thank you so much, Dr. Satish, Dr. Jagdish, and all the attendees. Thank you, sir.
Thank you, Dr. Ambardar. That was really very, very informative. You can stop the screen sharing so that others can participate. Yes. So thank you very much, Dr. Kalan. Wonderful presentation. And it's amazing how you not artistically do it with help of technology. Wonderful. So the house is open now for comments and questions.
Congratulations, Kalan. Wonderful presentation. I'm amazed to see how you can move the maxilla. I'm just wondering what happens to nerves and vessels.
Yes, sir. Sir, it is a question. I mean, it is a very important question, and this has been an age-old question, I would say. The person that I showed, Hugo Obbeseger, had the same challenge, sir. There's a little bit of history to it that when they were trying to move these maxillas, they would generally go for avascular necrosis because the vessels would practically give away, and we have to cut the vessels. Some of the vessels have to be cut. But what he realized is that if the drape of the periosteum of the maxilla is the actual supply. It's not just a single vessel. It is more than that. It's the drape around the maxillary segment. So he preserved the greater palatine from below, the soft tissue drape, and designed the cut in such a way that the bones slide over each other, and so that again blood supply is maintained. So with that, now almost if the surgical principles are not violated, even if we cut, the principle is that even if we cut certain arteries like descending palatine or nasopalatine, we don't lose the maxilla. Maxilla is lost in if there is overstripping of mucoperiodontium. So overall, it is a challenge. Yes, it's not a straightforward surgery, but if principles of surgery are not violated too much, generally we are able to preserve the maxilla as such.
How many case series you have now?
Sir, we have more. We started, I think, 2 years ago, and we have more than 14 to 15 anterior maxillary distractions. We have a few orthognathic surgeries. I'm talking about mainly cleft patients, because the aesthetic ones are generally done outside. The patients generally opt for private facilities, but here we have been able to. And one more thing, sir, is that in these cases, the orthodontic preparation takes a lot of time. So if the patient comes to us today, the orthodontic preparation takes around 2 years, 1.5 to 2 years, because we have to the orthodontist aligns the teeth in such a way, in a particular way, so that after the surgery, it fits perfectly. Because right now the patient will come with a compensated occlusion like this. So the orthodontist will increase the gap between the two jaws so that when we do the surgery, it comes perfectly. So because of that, now we have started in the last 6 to 8 months, started performing surgeries which were planned since 2 years. So the planning does take some time, but we are turning cases now regularly.
Amazing, wonderful work.
Thank you, sir.
So this 3D printing is outsourced or it is done in-house?
No, sir, it is outsourced. There are many 3D printing houses. Normally, sir, the preference is that the person performing the virtual surgical planning is the person printing. Because VSP, sir, the catch here is that the software, the virtual surgical planning software is very expensive. It runs into somewhere around 6 to 8 lakhs. So it's the affordability becomes an issue. And if we want to own a 3D printer, it will be an additional 1.5 to 2 lakhs. So a lot of companies, a lot of small houses have opened up across the nation, where what we can do is I can send my data to the company and they will plan it on Zoom with me virtually. So I don't need to be physically present for planning this case. What we'll do is I will interact with the person who's having this software, who's lending it on rent. And I will be like, okay, move the maxilla a couple of millimeters in front, move the mandible 6 millimeters behind, rotate it in this direction and show me, okay, this is not what I want. Then I will have my orthodontist sit with me and we'll plan it together. So once the position of the jaws is customized to that's where the surgical planning comes in handy. So it is our plan, but executed by a computer professional. And once we are satisfied that, yes, this is where we want our new position of the jaws to be, at that point, they make a splint between the two jaws, that negative impression they take. And that information they send to a 3D printer. That 3D printer can be near them or anywhere, but generally near them. And then they'll courier it to us.
Wonderful teamwork. I think it requires a lot of teamwork.
Yes, sir. Yes, sir. It's the surgical planning for orthodontic surgery, especially, is a very detailed effort. I mean, a lot of factors go into it. So yes, it is a teamwork, and we are building that team in our hospitals. We have successfully performed these surgeries, and we are on that path so far.
So this software is AI driven, I guess.
It is AI driven, sir. But actually, this software is an engineering software in which they would print a 3D printing software. It is basically a 3D printing software, sir, in which the cuts are predefined. We can perform the same virtual surgical planning. In fact, I mean, sometime I can show that I have a software in which the 3D planning can be done. Like these molds can be created, plastic toys can be made. So that is done via graphics and animation. Now, if we put a CT scan in that animation, we have what we need. The only thing is the cuts of the surgery. I will have to physically do it meticulously to replicate how it's to be done. But in a software, it's predetermined. The software already knows where the surgical cuts would be in a sagittal split, in a Leefort 1, in a Leefort 2. So that way, virtual surgical planning, it's not a typical definition of AI, because the concept is much simpler, but AI is coming into this rapidly. So now the cutting edge future is that maybe we don't need virtual surgical planning pre-surgery, we need it intra-op. So that is, if we are able to have an in live CT scan of the patient, we can take the patient in, osteotomize, put the patient in CT scan and virtually see live where we want it to be. This is a thing of the future, not very commonly done. That's where AI would be more productive, I would say.
Right. So how much does it cost? I mean, are you doing this under the project of Smile Train only, or these are now beyond that project, these surgeries?
Sir, so Smile Train does offer funding for orthognathic surgery. But we have not opted for it right now because we are still in building up our cases. So we have to, we have funding for every surgery, and this is something that we started recently. Once we have a decent build up of cases, we will present it to Smile Train, and we will tell them that we have an accomplished team, we have the adequate skill, knowledge, everything to execute such kind of cases. Then the reason why we would do this in future is if they are able to provide us with a software, because it's an expensive software. So currently we have to sublet our cases for virtual surgical planning. We have to rent out some companies. We also have an in-house software that I recently procured in Kochi. There was a wonderful conference there, OsteoMold, by Dr. Sherry Peter. He's a very well-known craniofacial surgeon. So he under him I learned how to use the software Mesh Mixer, which can be used, and we are currently planning to use that for some time, and then probably approach Smile Train. Currently, for these surgeries, we don't have funding, but we are looking for CSR initiatives also for patients who can't afford.
So it's a cosmetic surgery, so there may not be any insurance also, I think.
Sir, we sometimes get insurance because these are not, although the cosmetic effect is cannot be overruled, it is the main reason why orthognathic surgery was born. But in our patients, the kind of severity which we get between the maxilla and mandible, the disharmony is so high that it becomes a functional case rather than an aesthetic case only. By functional case, I mean that since the upper and lower jaws are not meeting, the patient is not able to chew. So they are doing like something like this constantly. So they are not able to chew. They don't have any occlusion, and which puts pressure on their joints. So it becomes a complex issue of function more also rather than only aesthetics. So but what you said is absolutely right, that insurance is very difficult to.
Coming back to my question, how much does it cost to the patient?
Sir, the virtual surgical planning software?
Yeah, everything. I mean, all included in the surgery. Or how much?
Oh, the surgery, sir. Surgery varies depending on multiple factors, sir. But somewhere between a minimum of we are very economical, 60 to 70,000 total. It will go up till 1.5 lakhs to 2 lakhs. But those are again very private patients and hi-fi rooms and all that. But we do it as low as 60 to 70,000, the entire thing. I'm not including orthodontics in it because orthodontics is a long process over 2 years. That may be an additional 20-30,000. But so within a lakh, we are trying to finish this entire thing. And we've done it for many patients because they can't afford, and we give them time. We give them assurances that you take your time. At a certain age in the life of a cleft child, this surgery will come, collect some money and we'll try finding some people from CSR. Then we approach certain people who are ready to fund, and whatever we manage, but somewhere around that value, sir.
So thank you, Jagdish Bhai, for introducing Kalhan to our Saturday club. And as I discussed with him, he has many such interesting topics with him. So maybe in coming months now, we will have you again, Dr. Kalhan. Thank you very
Sir,
much
thank you so
for
much. It is,
your
it
knowledge.
This
is,
way you may
it-
know his father. His father is pediatrician.
I know actually, I came to
Yes.
know about that. I know his
Yeah.
father.
Yes, sir. And sir, I would like to really extend my gratitude for this opportunity. It's really a privilege to be among such accomplished individuals. So thank you so much to
The
Jagdish sir and Satish sir
contrary,
and
on
everyone.
our part, no, we are it's very heartening to see young people like you doing wonderful, work in your field. So all the best for future, and we hope
Thank
to
you, sir.
see lots of talks in future. So thank
Thank
you
you,
all
sir.
for
Thank you.
joining, and we
Thank
meet
you.
again next time. Thank you. Thank you.
Thank you.